So my name is Joanna. I'm one of the pediatric registrars at Queen Elizabeth Hospital in Woolwich. And as just Katie mentioned, following our very popular teaching that was done by one of our colleagues, Rashmi, in late April this year, the presentation that I'm bringing today, it's entitled How to Approach a Febrile Child in a COVID-19 Era in a DGH setting, and I hope everyone enjoys it. So this is a brief summary of my presentation. So I'll go through timeline, definition, and context, our data collection and our main results, the management of these patients, some hot topics for discussion, and then what were the outcomes, conclusions, and take-home messages from the presentation. So as I'm sure everyone remembers well, in mid-April 2020, there were some cases of a new hyperinflammatory syndrome described in children, and this was an unusually high number of cases that were raised, and obviously there were some concerns. There were a lot of discussion with Public Health of England about this new unknown condition and whether this could have been an infectious diseases cluster that we were not entirely sure of the pathogen cause. So after multiple discussions in the 1st of May 2020, the Royal College has released some guidance on what they have called PIMS-TS case definition, being PIMS-TS pediatric inflammatory multisystem syndrome temporarily associated with COVID-19. So interestingly, right in the beginning, so around late March, beginning of April 2020, the Queen Elizabeth Hospital has noticed a very significant number of children that presented to our emergency department with features of both toxic shock syndrome or Kawasaki disease. We were not entirely sure at that time, but all these children presented in a very, very similar way, and they ended up having a significant clinical deterioration, needing to be retrieved to PICU for cardiovascular support. So a few days after the Royal College publication, on the 7th of May, there was a letter published to the Lancet with the very first case description of 8 cases with this new hyperinflammatory syndrome, and this was done by the South Thames Retrieval Services at Evelina. And interestingly, out of these, so 5 out of these 8 patients that were first described, 5 came from Queen Elizabeth Hospital. Following this, a lot of information was then released. So by the 15th of May, the World Health Organization has also released some guidance on this new hyperinflammatory syndrome. And then further cases were basically described worldwide, namely in Italy, France, and US, which were areas that were heavily affected by the COVID-19 pandemic. So as a brief mention of how PIMS-TS was defined, so the common feature present to all patients with PIMS-TS is the fever and the inflammation, and being inflammation as neutrophilia, elevated CRP and other inflammatory markers, and lymphopenia, and then evidence of single or multi-organ dysfunction, namely shock, cardiac, respiratory, renal, GI, or neurological affection. And then some other associated symptoms that were seen in many of these children were GI symptoms, namely abdomen pain, diarrhea, vomiting, some confusion, red conjunctiva, and skin rash. And then some other patients presented with cough, some coryzal symptoms, mucous membrane changes, sore throat, and so on. Importantly, as part of the definition of the PIMS-TS, there needs to be an exclusion of any other microbial causes, including bacterial sepsis, staph or strep infections, and infections associated with myocarditis, namely enterovirus infection. And then the SARS-CoV-2 PCR from the nasopharyngeal swab can either be positive or negative. So just so you guys know where Queen Elizabeth Hospital is, we are a district general hospital in South London. We cover a population of 66,000 children, being 62% from a Black and minority ethnic group. So we have had 17 children that presented to Queen Elizabeth Hospital with signs and symptoms that met the Royal College definition for PIMS-TS. And we will summarize in this presentation the clinical and biochemical picture of 17 children that presented to us and discuss some of the challenges of the diagnosis and the management in the context of our local emergency department and our general pediatric ward. So we have collected data retrospectively over the period of 3 months, so from the 14th of March to 18th of May, and we have identified these 17 children that met the Royal College definition of PIMS-TS and ended up being transferred to a tertiary unit for management. And we have collected demographic data, symptoms, duration, clinical findings, observations, and some results. So baseline blood tests and the kind of treatment that we've done just prior to the transfer. So in our 17 children case series, we have had 12 males and 5 female children, and the median age presentation was 11, with patients ranging from the age of 1 to the age of 16. 15 out of 17 were fit and well, and 2 patients had a significant past medical history. So one had lupus and the other one had epilepsy. The patient with lupus was on some immunosuppressant medication. In terms of more demographic data, 7 patients were Black African and 2 patients were Afro-Caribbean. 6 patients were white, so 3 were Caucasian and 3 were Eastern European. 1 was Asian Indian and 1 was Hispanic. 4 children had members of the family that were classified as key workers during the COVID-19 pandemic. And in none of the 17 children, there was any previous description of infection or respiratory symptoms or even fever in the preceding 6 weeks prior to their presentation. So this is the signs and symptoms that our children presented with. So as you can see, 100% of the children had fever. And then again, I think very interestingly, the GI symptoms were a hallmark picture in all our children. So vomiting, abdomen, and diarrhea were present in a very high percentage of the children, and then followed by the red conjunctival injection and the polymorphic rash. And then less common, but seen as well, were the hand and feet swelling, epistaxis, cracked lips, chest pain, and then in a very, very few cases, some respiratory distress and cough. The median temperature was significantly elevated, being 39.1, and then 10 children were tachycardic, 9 had a low blood pressure, 4 were tachypneic but had normal saturations, and the blood gas was roughly normal to all children with a slightly raised lactate as a medium. This is a lot of information, and I will leave you a few seconds to look at it, but I have also done a summary of the most important findings. So I think it's worth mentioning that most of the children presented with lymphopenia, with our lymphocyte count with a median level of 0.6, and then significantly raised inflammatory markers. So elevated CRP, elevated ferritin, and elevated LDH. Not all children had cardiac markers, because at that time, again, we were not entirely sure what we were dealing with, but the ones that had, 3 out of 12 had raised troponin T, and 2 out of 6 had raised BNP. 8 out of 8 children who have had fibrinogen and D-dimers, they were all elevated. Again, 8 out of 17 children had abnormal renal function, and 10 out of 13 had a low vitamin D level. In terms of microbiology investigations, I think it's worth mentioning that 1 urine culture came back positive for E. coli, and 1 stool culture came back positive for Salmonella. 15 out of 15 children that had SARS-CoV-2 PCRs tests for their on the nasopharyngeal swab, they all came back negative. In terms of management, 12 out of 17 children received ceftriaxone and clindamycin. And I believe it is important to mention that we have done this because I think most of these children presented with what it seems to be toxic shock syndrome, with the fever, the GI symptoms, and the skin rash. There was one child that additionally received acyclovir and gentamicin. I believe the acyclovir was added because of a very, very significant headache, and there were some concerns about encephalitis. 3 were treated only with ceftriaxone. 1 received PIMS-TS, gent, and clindamycin, and this was a child that had immunosuppressant therapy. And 1 child was treated as abdominal sepsis with ceftriaxone, clindamycin, metronidazole, and gent. In terms of further treatment, 1 child received IVIG prior to transfer. This child was the one that fulfilled the criteria for Kawasaki disease. However, he did not respond to the IVIG, and he further deteriorated whilst on the ward and ended up being transferred. 11 children required fluid resuscitation with fluid boluses up to 60 ml per kilo. There were 4 that required peripheral inotropes prior to transfer. 1 had to be intubated and ventilated for cardiovascular stabilization prior to transfer, and 10 children were transferred within the first 24 hours of admission. So in terms of discussion, so over the period of 2 months, we have seen 70 children that presented with a hyperinflammatory syndrome, with persistent fever, with very obvious GI symptoms, conjunctival injection, and a rash. All of them had raised inflammatory markers and lymphopenia, and no identifiable microbial cause at the moment of transfer. So they all fulfill the criteria for PIMS-TS. And over half of these patients were hemodynamically unstable, requiring resuscitation prior to transfer. So I think this is probably one of the most important slides in this presentation. So was this really PIMS-TS in all of them? So probably not, as we will see. So 2 children came back then with positive microbiology results, but obviously these were not known at the moment of transfer. And as a pediatric registrar in a DGH setting, I think it's very important to highlight this, because when you're dealing with these sick children with a prolonged fever, very high inflammatory markers, with no obvious source of infection, then what do we do? One of the child ended up having an E. coli in the urine, and the other one was a salmonella in the stool culture. But so by the time of transfer, PIMS-TS could not have been ruled out. So PIMS-TS is proving challenging to diagnose in the emergency department for multiple reasons. Number 1, for the heterogeneity of the clinical presentation and the laboratory markers. And then some children present hemodynamically unstable and need transfer and retrieval as soon as they present to ED, whereas others are stable enough to be admitted to the ward and being monitored. And then what we've seen is these children ended up deteriorating, needing resuscitation and needing retrieval. Another important fact for being so challenging to diagnose this in a DGH setting is the substantial overlap with other pediatric conditions like Kawasaki disease, toxic shock syndrome, HLH, macrophage activation syndrome, and even very common pediatric presentations like gastroenteritis, streptococcal infections, UTI, and even appendicitis. So why have all our patients tested negative for SARS-CoV-2? We found this interesting, so we did a bit of literature search, and there is a paper that describes that the sensitivity of testing of SARS-CoV-2 in a single upper respiratory tract infection in a symptomatic patient is 86.2%. So this fact, along with the fact of difficulties or even inappropriate sampling in children of the nasopharyngeal swab, and probably the fact that none of these children were actually having acute COVID-19 infection, but rather a past infection, all of these might have contributed to our negative results in all children. In terms of published data, I believe similar results were found by other colleagues. So the Italian study by Verdoni et al. About 10 patients with a hyperinflammatory syndrome very similar to Kawasaki disease that was described again in early March, it shows that only 2 out of 10 children tested positive for the SARS-CoV-2 PCR swabs, but 8 of these 10 children had evidence of serological infection. Similarly, the 8 children from the STRS cohort, only 2 tested positive for the SARS-CoV-2 PCR. The study done by Whittaker et al. With 58 patients presented in England with PIMS-TS, only 15, so 26% had positive SARS-CoV-2 PCR swabs. So again, a significant, low percentage of children. And then finally, White et al. With 17 children from Evelina with PIMS-TS. What they don't mention any numbers, but they again say that most patients with PIMS-TS were SARS-CoV-2 PCR negative. So who should have investigations? Again, it's not possible to do a full PIMS-TS investigation to all children present to our pediatric ED with fever, with no obvious focus. But our main goal here is to avoid missing cases, especially because PIMS-TS can have quite tragic consequences, especially from a cardiac point of view. So we think a lower threshold for investigation is needed, but this can also lead us to some problems. So number one, difficulties in interpreting abnormal results in a context of a well child with fever. So it's not entirely known how the D-dimers, the LDH, CK, and ESR are distributed in, common respiratory tract infections, common UTIs. So that can lead us to a problem with difficulties in interpreting these results. And the other situation here is the tertiary centers will probably cannot accommodate all these children that present with fever with unknown source, because they might reach his full capacity. So we obviously need to have a very well pathway defined for whom needs to be transferred for inpatient echocardiography in a tertiary center. So I believe that the main goal here is to identify the children that presented with fever, and then with the conjugation with symptoms and signs that are suggestive of PIMS-TS, we should do some baseline investigations. And then if the results of our normal baseline investigation come very abnormal, then we should probably do further investigations. We should do a risk stratification for admitting these children to our pediatric ward, and then have a very, very low threshold to discuss with the tertiary centers, and then eventually transfer the patients that are unstable for cardiac function and coronary aneurysms echocardiography to make sure that we do not miss any cases. In terms of the outcomes of our cohort, which I believe I think everyone should be interested to hear about. So 11 out of 17 patients in our cohort were confirmed to have PIMS-TS. So unfortunately, one patient passed away, and this patient was cardiovascularly unstable, needing ECMO, and as a complication of ECMO, he developed a very extensive right MCA and ACA stroke. And this was the patient that the post-mortem revealed SARS-CoV-2 positive. 8 out of 11 patients had myocardial dysfunction and coronary involvement. Only 2 ended up being positive for SARS-CoV-2 PCR. Additionally, 3 had positive serologies. 2 were completely negative for either serologies and PCRs, and 4 had no results available. And so far, none of these patients seem to have had any long-term consequences of relapse of PIMS-TS. Interestingly, the other 6 patients ended up not being PIMS-TS. So one was diagnosed with toxic shock syndrome, another one with cellulitis with prepectoral abscess, one Kikuchi Hashimoto disease, one with sepsis, one with E. coli UTI, and one with appendicitis needing surgery. So our conclusion, as a general pediatric department in South London, we have identified the need to review our threshold for blood tests, admission for observation, and early discussion with the tertiary centers for an MDT involvement. And we hope to raise the awareness of this condition and generate discussion of our practice amongst general pediatricians, ED doctors and even GPs, because these are the ones who actually normally see these children as a, first line. Very briefly, take-home messages. PIMS-TS can normally present with fever, GI symptoms, and non-purulent conjunctival injection and a skin rash. Lymphopenia, raised inflammatory markers, and abnormal cardiac markers are frequently seen, and these patients can either be positive or negative for SARS-CoV-2 PCR. There is a significant overlap with other pediatric conditions, namely Kawasaki disease and toxic shock syndrome, and these patients are difficult to manage in a context of a DGH, and it's important to create specific pathways and early transfer to tertiary centers. This is the feedback form, please, which I would kindly ask everyone, if possible, to fill, and thank you so much.
Thank you so much, Joanna. That was really great. I'm sure people have a lot of questions, but I'm quite aware that Michael might answer some of those. So maybe if we move on to Michael's talk now, and then we can have questions together at the end, if that's all right.
Thank you.
Hi, guys. Can you hear me okay? Joanna, thanks for a wonderful talk. I'll share my screen. I've just got, for some reason, something or other. I'm sorry, I've just got to redo something to share my screen. I'm just rejoining you. Hi, good. Hi, everyone. I hope you can hear me okay. Could someone just shout out yes?
Yep, we can hear you.
Fabulous, thanks. Just had to change some of my security settings. Anyway, lovely to be here, and thanks for inviting me, Joanna. Thanks for a fantastic talk. I think we at Evelina were very aware of everything you guys were going through in Woolwich and a few other epicenters of PIMS-TS in the early days. Kingston also had a lot of cases, and obviously north of the river, who knows what goes on because we live in our silos, but I know that friends at Gosh and St Mary's had an awful lot to do with the early work of PIMS-TS as well. So I'm at Evelina London Children's Hospital in the PICU there, but I also do research with King's College London as an immunologist and paediatrician, obviously. So if I just talk through some of the data that we have on the immunology of PIMS-TS, it may answer some of the questions that Joanna raised, but it will certainly raise more questions, as all good research should do. So Joanna, you described very nicely the early cohorts of PIMS-TS, or MIS-C, as it gets called in some of the literature, particularly from the US. And there was the initial case series of 8 children who presented with hyperinflammatory shock in April. Retrospectively, there are actually 1 or 2 cases, including one from Woolwich, who probably had a milder version of PIMS-TS that came up to us at Evelina and was probably unrecognized and got better to some extent. But as you said, the first 8 cases in the case series were fairly dramatic, including the big child who died with us on veno-arterial ECMO, which obviously has a high risk of stroke. And sadly, he, with his hypercoagulable state, suffered a very large stroke. What is really unusual about PIMS-TS is, as Joanna said, most of the children are SARS-CoV-2 negative. And in fact, when you look at the epidemiology of PIMS-TS, and some of the best data for this comes from the United States, where they were possibly a little bit behind us in terms of the epidemic, but certainly a little bit behind us in terms of identifying PIMS-TS. They were able to set up statewide reporting for MIS-C or PIMS-TS, and Dufault et al. Describe it really nicely, where they've got the epidemic of COVID-19 from mid-March onwards, but about 3 to 4 weeks later, there's the epidemic of MIS-C at a much lower incidence than obviously COVID-19. So MIS-C or PIMS-TS is a rare complication of infection with SARS-CoV-2 in children and young adults. And quite why it occurs in this age group and not so much in adults, and there's lots of caveats around that statement, is at the moment unknown. So although there was that letter to the Lancet from Evelina, and mainly using Woolwich patients, actually the Italians were very aware of cases of Kawasaki-like disease that were occurring in the Bergamo region through March and April, and also produced a very nice analysis of that in the Lancet. And so pre-COVID, Kawasaki disease with young children, and they had the classic features by and large of Kawasaki disease. That's how we made the diagnosis. But MIS-C or PIMS-TS, children tended to be older. They tended to have a predominance of abdominal symptoms and less or fewer symptoms of cough and rash and conjunctivitis, although they were still fairly predominant. So when we've gone on to look at this with these radar plots, I think you can see quite nicely. Here on the left, you've got, in red, you've got PIMS-TS. And if you move around the radar plot, you can see the different age categories, the different systems involved, and the different treatment needed in terms of vasoactive infusions and complications, including coronary aneurysms and mortality. PIMS-TS actually looks relatively different from Kawasaki disease, largely because of the GI symptoms, but also the cardiac involvement and the need for vasoactive infusions. What PIMS-TS actually looks like is toxic shock syndrome. And the severe cases, including the child who died back in the middle of April, were initially diagnosed as toxic shock syndrome. We're still seeing these cases come through. We had a very severe case come through on Sunday afternoon when I was on, and they still look like toxic shock. But the ability for us to identify it quicker is actually very helpful, because we know that with support, with vasoactive infusions, with immunomodulation, and obviously with antibiotics to cover in case we make a misdiagnosis, these children will get better. And that's prevented us from putting some children onto ECMO when, if we thought they had toxic shock syndrome, we probably would have done, with all the added complications that that has. So Joanna, you briefly touched on what is PIMS-TS and how that contrasts with KD, Kawasaki disease and Kawasaki shock syndrome. What you see in PIMS-TS is that the ferritin is much higher, and I'll show you later, it stays high as well through the course of disease. Troponin is also very high, and the cardiac involvement in these children is enormous. So our case on Sunday had a fraction of shortening of 6%. Less than 28% is abnormal, 6% is incredibly low. And we're probably hopefully sitting here with fractional shortenings of about 40%. And they also have this hypercoagulability. So you can see the D dimers here on the far right are very raised, which is of course one of the reasons why the child died with a stroke. I wanted to touch on the immunology though, because this is something where I think we've been able to make a little bit of progress, and I can talk about that. And we have 4 by no means mutually exclusive hypotheses for the immunology of PIMS-TS, and lots of groups around the world, and actually really around London, are working hard on this at the moment, and working together, which is a really good thing. And one of the nice things about this as well is that it's along with the clinical work being driven by SHOs and registrars, a lot of the immunology work as well is being driven by us youngsters, who perhaps are a little bit more flexible with thinking about novel diseases. So we've got one big body of work looking at impaired antigen presentation and whether the production of autoantibodies or neutralizing or non-neutralizing antibodies that enhance disease are underpinning some of this syndrome in terms of a mechanism called antibody-dependent enhancement of disease. Now, some of you may have come across that as a concept. I think autoantibodies are fairly self-explicable, as with, for example, systemic lupus. You could theoretically have antibodies that attack, for instance, the myocardium, that would cause the symptoms of PIMS-TS, at least in part. But antibody-dependent enhancement of disease is when you have antibodies that bind the SARS-CoV-2 virions, which you can see as little sort of orange circles with little bitty antigens sticking out of them. They bind those virions, but instead of neutralizing them, they actually allow them to invade host tissue. And host tissue might be the endothelium of the coronary arteries, for example. Now, SARS-CoV-2 by itself wouldn't be able to invade the coronary arteries because, as most of you know, it binds to the ACE2 receptors in the respiratory tract, and that's how it enters the body. But if it was bound to an antibody, and that antibody bound the antibody receptors that are on the endothelium of the heart, then that could augment its invasion. And that's one of the key thoughts for the mechanism of PIMS-TS, and also of very severe COVID-19 pneumonia in adults. And that mechanism certainly has occurred in previous coronavirus infections, such as MERS or SARS-1, and is originally explained as a rationale for why in dengue infection you can become very unwell with your second dengue infection, but not normally your first, because you don't, in your first infection, you don't normally have antibodies that would be able to do that. Other possibilities are that there's impaired interferon signaling, which means that the virus isn't cleared. And there's a little hint of that from that boy that we've discussed, who sadly came up from Woolwich and died on ECMO with us, in that he had probably been exposed to COVID, to SARS-CoV-2, about 6 to 8 weeks prior to presenting here. Now, normally the immune system would have been able to clear the virus in that period of time. But if there was impaired interferon signaling, particularly interferon alpha, which is probably the most important interferon for clearing SARS-CoV-2, then you can have this situation where you get a subacute, chronic, severe cytokine upregulation leading to unchecked inflammation. Now, that's a hypothesis that we're following up in the lab. And interestingly, last month, there were a couple of papers looking at adults with very severe COVID-19, some of whom go on to get hyperinflammation a few days into their mnemonic illness. And that hyperinflammation is associated with impaired interferon signaling too. So that's quite a likely hypothesis, I think, at the moment. So our original work in the immunology lab was based on the cohort of children that were enrolled to a study at Evelina from the 28th of April to the 25th of May, so the first month of the study opening. We took blood samples at time point 1, time point 2, and time point 3. Oh dear, there's some drilling going on. I hope that's all right. And you can see here in the diagram, this shows the clinical trajectory of children with PIMS-TS. In orange on the left, you've got their prior fever, prior to admission to hospital. You've got the sampling time points T1, T2, and T3, and then we've got the treatment time points here. And their location is in blue and green in terms of where they are in the ward, the PICU, or in green in convalescence. And what we saw is that children's hemoglobin levels stay relatively stable. Their platelets, which are normally low, tend to rise during the course of the illness, as indeed happens in Kawasaki disease, and their CRP comes down relatively quickly. The ferritin, on the other hand, stays high, the time point 1 being near admission, time point 2 being clinical improvement, and time point 3 being convalescence. So they've got chronic inflammation, despite the fact that they're getting better. They also have disordered coagulation, which improves over time in terms of the fibrinogen and D-dimers coming down. And they've got raised cardiac biomarkers. So the troponin T, that dashed line there is where you would almost certainly diagnose an acute MI in an adult. You can see that most of the children are above that level. Their NT-proBNP levels, which are a marker of atrial stretch and cardiac failure, are through the roof. Really very, very high. And their left ventricular fractional shortening is also impaired. And that cutoff there is that 28% that I mentioned being the cutoff for normal. Interestingly, you can see patients colored in blue or in red. On this corner in the bottom right, you see the serology positive patients in red having much more impaired left ventricular fractional shortening than the patients in blue who are serology negative. We don't know whether that's because some of the serology negative patients actually had other diseases, although I don't think that's the case, or whether there's something very important about being serology positive in terms of severity of disease. So what immunomodulation is used? Well, we initially started using intravenous immunoglobulins, and that quickly spread from being a tertiary center thing to something that was used relatively quickly in these patients. The rationale behind that was that it's a very good immunomodulator. Second rationale was that it's used in Kawasaki disease to prevent coronary artery aneurysms. And some of the key problems we had with our patients, particularly in the beginning, were the large coronary artery aneurysms. Thirdly, it's also indicated for toxic shock syndrome. So it makes sense if you're uncertain of the diagnosis to give IVIG anyway. And fourthly, it's something we had a bit of experience with. And although it's not entirely safe, it is obviously a blood product. It's something it has known difficulties rather than unknown. We also use a lot of corticosteroids, and most of our patients admitted here have had corticosteroids as well as intravenous immunoglobulins. And then we moved on to looking at biologics. So the most frequently used is interleukin-6 inhibitors such as tocilizumab, but we have also used anakinra, which is an interleukin-1 receptor antagonist, or infliximab, particularly in the patients where there's crossover with what might be Kawasaki disease. Is there a rationale for these biologics, though? When we started using them, no, I think is the honest answer. We thought they might be useful. We thought there was a cytokine storm going on. We didn't know which one would be best, and so we tended to flip between them. This here shows on the right shows the cytokine levels for the patients recruited to the study that I'll be talking through. And as you can see, most of the cytokine levels are raised well beyond the healthy normal level, which is marked in grey on the graph. Increasingly, there's a little bit of evidence from adults that tocilizumab may be beneficial in adults with COVID-19 pneumonia and with hyperinflammation at the same time. So that's why tocilizumab has been added to the PIMS-TS recovery trial protocol that I'll talk to you a little bit about right at the end. Coming back to the biology, and here we're following the same pattern of the graphs with time point 1, time point 2, and time point 3 with the patients coloured by red or blue dots, depending on whether they're serology positive in red or negative in blue. But we've also added in healthy age-matched controls as well, and ethnicity-matched controls. And this data shows work from flow cytometry that we did in the lab at King's. What you can see is that neutrophils, as well as being very high, as Joanna explained, in terms of their count, are highly activated. So they've got high expression of the Fc gamma receptor 1, which is demarcated CD64. They're also young neutrophils. They've got very low levels of CD10, which is a marker of old neutrophils. And there's also impaired antigen presentation. So monocytes and on other graphs that I don't show, dendritic cells have got very low expression of HLA-DR and low expression of CD86, and CD86 is involved in antigen presentation to T cells. So neutrophils activated, impaired antigen presentation. T cell subsets are low throughout across all different T cell subsets, whether it's total T cells, CD4, CD8 cell T cells, gamma delta T cells, which are involved in immunomodulation, or T regulatory cells. We don't know whether this is because they're genuinely low in the whole body or whether they're egressing from blood into lymphoid follicles, for example. There's a little hint of that if we look at the T cell activation, that actually in time point 1, CD4 positive T cells express more HLA-DR, and particularly those that are also expressing the lymph node homing receptor CCR7. So it looks as if at least some of these, some of the T cell lymphopenia is actually because T cells are moving to the peripheries where they may be fighting an infection or fighting a perceived infection in these children. So I mentioned a couple of slides back, there's a hint that there's a defect in antigen presentation. So one of the things we're obviously interested in, and particularly because of the hypotheses around whether this is an antibody-mediated disease, was whether there was a germinal center independent B cell response. And what we mean by that are that B cells produce antibodies without going through the normal affinity maturation process. So the antibodies are less affined to the SARS-CoV-2 antigens. There's a little bit of evidence for that. You can see that, that the CD27 IgM negative B cells in graph K there, which are the memory B cells that are producing immunoglobulin G or A, are actually relatively low at time point 1 relative to time point 2 and time point 3. Bearing in mind that time point 1 is probably 6 to 8 weeks after primary infection with SARS-CoV-2, if you look at some of the epidemiology that I showed on the first slides. I think that's really fascinating. There's clearly is evidence of an aberrant B cell response in these patients. And you can also see that the HLA-DR on total B cells is also low during the acute time points, suggesting that there's poor antigen presentation going on from B cells, because B cells, of course, also present antigens as well as producing antibodies. So further evidence of impaired B cell function, where there are very few plasmablasts at T1, but actually that goes up at T2. Plasmablasts are acute antibody secreting cells that tend to transiently circulate about 7 to 10 days after primary infection. And again, this is 6 to 8 weeks after primary infection, we think. So it's unusual for us to see plasmablasts this low. Similarly, CD5 positive B cells, which denote signal transduction through the B cell receptor, also very low in the acute time points. So the next obvious question for us to look at was whether serum antibody was associated with disease. And there were hints of that, as I showed on one of the graphs earlier, when we saw that patients who were serology positive had far worse cardiac function than those who were serology negative. In graphs A, B, and C here, you can see that over time point 1, time point 2, and time point 3, patients who are serology positive at time point 1 tend to continue to have high ELISA levels to spike nuclear protein and receptor binding domains throughout the time course of disease. So we don't get a, for example, a waning or an increase in the affinity of antibodies during time points 1, time point 2, and time point 3. In graph D, the ID50 PRNT is just a measure of how effective these antibodies are at killing the virus. And again, patients who are in red tend to have effective antibodies. So although that doesn't totally rule out antibody-dependent enhancement of disease, which I showed you in one of the earlier slides, it does mean that when these antibodies bind the virus in the serology positive patients, they do tend to kill the virus, which means that it's less likely for them to bind the virus and inadvertently allow the virus to invade the endothelium of the coronary arteries, for example. So the further hypotheses, well, we're still working on the impaired antigen presentation and antibody story. And this is work that's really being led through the Diamond study, which is led by Mike Levine, but Harsita Patel, who many of you will know as one of us youngsters. I count myself as a youngster still. Is working up, and we're looking quite closely at the interferon signaling in collaboration with the Diamond study and Manu Shankar Hari's lab at King's. In terms of, or one of the missing parts of the whole PIMS-TS story is the comparative immunology. We've looked at the comparative clinical phenotypes, and you can see that there's a lot of crossover with toxic shock syndrome. But there are some data coming out of other labs. In graphs A and B, you can see data from Petter Brodin's group up at the Karolinska in Sweden, where if you look at graph A, you see what's called a principal component analysis. What that does is it tries to take many, many variables, some of which you can see on graph B, which are related to the immune system, and then plot individual patients on a two-dimensional graph that takes into account all of the different variables. And you can see in the top left of the graph in green and purple, you've got adult COVID-19 patients who do and don't require intensive care treatment. In the top right, you've got a sort of plum-colored children with Kawasaki disease. And then by and large, spread over the bottom half of the graph in gray, you've got patients with PIMS-TS. Now, the exception that proves the rule is that you've got 3 patients in gray diagnosed with PIMS-TS or MIS-C, who also fit in to that Kawasaki bunch in the top right. Now, almost certainly, they've got Kawasaki disease, but they just happen to be presenting to the hospital in Italy or Sweden, where these data are from, at the same time as PIMS-TS was going on. And I think that's interesting because it brings it right back to the F2 or the SHO in the emergency department in Woolwich or Kingston or Tommy's, trying to differentiate between Kawasaki disease and PIMS-TS. And actually, it's bloody hard. So even these top researchers are struggling to do it by looking at the immunology. If we just look over at the far right, you can see another principal component plot, this time from workers in New York State. And you can see again that you've got active MIS-C in yellow and convalescent MIS-C in these sort of hashed yellow pockets there. So you can see how patients change from being acutely unwell with MIS-C to being better and heading towards a phenotype that fits more closely with normal COVID in children, i.e. not too severe. So plenty of further work to do. Lots of big questions. The obvious one is how to discriminate between PIMS-TS and other syndromes, and the second one is what is the best available treatment. Lots of other epidemiology as well that needs to happen. What are the long-term outcomes? Is there a cadre of children with this disease who went unrecognized and have now got coronary artery aneurysms and are walking around with them? What are the mechanisms of PIMS-TS, which I touched on? And then what are the implications for vaccines? That we don't know. And that is a really, really important and interesting area. So in terms of being an advocate for research, many of you will know about the Diamond study. Fantastic that Woolwich and Lewisham are recruiting patients to that, because I think that's just brilliant at lots of levels. I know it's hard work, but really important. For those of you who want to enter data, the best available treatment study, again led by Mike Levine at Imperial, is collating all of the treatment data for these patients. And then there is the recovery trial, which includes children with PIMS-TS. And it's a difficult trial because you're randomizing children to potentially no treatment, but you're able to treat them outside of the trial as long as you continue to record their data. So it's a really interesting thing to be involved with. So plenty of things to get involved. If you are around Evelina, or you just want to have a chat, feel free to email me or Julia at GSTT, and be delighted to talk. For those of you recruiting to the Diamonds study, I put omitted to Evelina here, but clearly if you're at Woolwich, Lewisham, or anywhere else where they're recruiting to Diamonds, please be aware and speak to your PI if you've got any patients who you think might meet the criteria. They're very broad. And of course, here's the obligatory feedback. If you don't fill out your feedback, you don't get Christmas presents this year. That's the word I hear. Thanks for listening. I'll stop talking now.
Thank you so much, Michael. I think that was really, really thought-provoking. I'm sure there are going to be lots of questions. I had a quick one, and I don't know if I missed it, but did you say that, is there any crossover with adults? You mentioned that maybe some adults got this, and is there a kind of, why are we seeing it up to a certain age and not further?
Yeah, thanks, Katie. I was hoping, dreading somebody would ask that. It's something that we spent a lot of time thinking about through May, when GSTT was overrun with adult COVID-19 as well. What tends to happen in adult COVID-19, as I'm sure you're aware, is that patients get very severe pneumonia. Well, if they're going to get sick, of course. Lots of people don't get sick at all, don't even become patients. But they get very severe pneumonia and their lungs deteriorate first. But then a few days into the illness, and it's typically 4, 5, 6, 7 days into the illness, some patients go on to develop hyperinflammation. The early data from us at King's and Peter Brodin's group at Karolinska is that seems to be associated with, weirdly, eosinophils and interferon gamma signaling. It's interesting it's interferon gamma, and I think what might be happening is that there's a skew from the type 1 and type 3 interferons, which clear viruses, so that's interferon alpha in the main, to interferon gamma, which doesn't clear respiratory viruses. And so these adults end up being unable to control the inflammation that's been set off by the virus. And then they get, in many ways, a very similar phenotype. It's just for them, the phenotype of hyperinflammation is also on the back of having appalling lungs with severe COVID-19 pneumonia. And that is one of the reasons why these patients have such a high mortality. Often patients die because of myocardial infarction and just their inability to cope with inflammation. These are adult patients, rather than just a pure pneumonia.
Thank you. That's really useful. Really interesting. I don't know if anyone else has any questions. Rashmi's put something in the chat, but I think she's just sent it to me. So maybe I'll read it out if that's all right. Oh, she's put it to everyone.
Oh yeah.
Yeah, Michael, it might be easier for you to read it yourself.
Oh yeah. So I don't know if anyone can see this, but oops, everybody, sorry. Okay, number one. How did the team in PICU decide which immune-targeted therapies to give during the initial peak? Good question. It was largely trying to figure out what we thought might work. IVIG made immediate sense because of the potential crossover with Kawasaki disease and toxic shock syndrome. In fact, these patients were diagnosed as toxic shock syndrome for the first couple of weeks until we realized what was going on. So they were being given that anyway. Steroids were occasionally given in some of these cases because of the hypotension. And just occasionally we will give steroids if patients are crashingly unwell with sepsis in order to boost if we've got inotrope resistant shock. So that was interesting. In terms of the biologics, it was rather based on an individualized approach, shall we say, to start with. Tocilizumab was being floated from the beginning as something in adult COVID-19, and IL-6 probably mediates a lot of cardiac dysfunction in meningococcal shock, for example, so it made sense to use TOC. Anakinra is used in macrophage activation syndrome and largely to counter the cytokine storm you get in MAS. So that was used with that rationale, and infliximab was used because of the potential as a potential therapy for Kawasaki disease. So if patients fitted down one arm or another, they tended to get that sort of therapy. The second treatment, the second question, do I think the serology results are false negative, or it's a non-antibody mediated hyperinflammatory state? Oh, Rashmi, what a question. If I knew the answer to that, I'd be a happy man. I don't think the serology results are a false negative. No, in terms of the test, they're definitely negative. We've worked them up in detail at King's as well as just in the normal GSTT lab. But yes, it could well be a non-antibody mediated hyperinflammatory state. What we could be seeing is that some of these serology negative cases are actually, they've got something else. They haven't got PIMS-TS. They've got culture negative toxic shock, but I don't think that's the case. And Victoria says something. Any idea why some places were worse hit than others? Yeah, I think, Vicky, I think that's, I suspect that the measurement of coronavirus transmission through February was so appalling. You remember that fateful week where the NHS decided to stop testing? That actually there were pockets of very severe infection, and Woolwich was probably one of them, as was maybe Kingston as well, and it was just by chance. Possibly some interaction with ethnicity, but teasing out ethnicity from socioeconomic status, from socio-behavioral effects is very, very difficult. Yeah, it's very difficult.
I have one more, maybe it's a really stupid question, but you've mentioned a few through these studies that there are children who just don't fit, and maybe they were a misdiagnosis because of various factors. Is it ever possible to kind of retrospectively write them out, or is that too dangerous? You end up missing like abnormal cases and things.
Yeah, that's a really good point, and it depends, I think, what your question is. I think if your question is on a simple basis, what should you do at the front door or in the first few hours of disease to treat these patients, then you shouldn't write them out, because the key thing is that these patients look like they've got what you're treating them for. Does that make sense? So that's one of the rationales behind the Diamond study, which is aiming to develop very rapid diagnostic tests for the etiology of childhood fever, which are going to be based on the gene expression profile of children. Where that becomes really important, as Joanna mentioned, is that in the COVID-19 PIMS-TS era, CRP is probably not a very good predictor of whether a child has a bacterial infection or not. In the old days, if you had a CRP more than 60, you had a very reasonable chance that it was a severe bacterial infection, for example. And as obviously the CRP went higher, you had more of an inkling that they had a severe bacterial infection. So if you are looking at what you should do, exactly as Joanna's described, in the district general hospital or the emergency department, then you shouldn't rule out these patients on the basis that they end up having toxic shock syndrome or genuine Kawasaki disease. But if you are looking at the detailed immunology, then I think there is a rationale for at least subsetting your analysis by whether patients cluster, for example, on the principal component analyses, into a Kawasaki disease cluster or a PIMS-TS cluster or a toxic shock syndrome cluster. And that unsupervised approach is the sort of technical term, does allow you to focus in on the immunology that may be very specific to that group of patients. But, and this is where it's important to have pediatricians or clinicians doing research, what you don't want to do is get carried away by repeatedly clustering samples of patients without relating it back to the real life, which is where they present in an emergency department. And this research will have real world implications for how they're managed.
That's great. That was really well explained. Thank you so much. All right, great. Well, if there are no other questions, then we might close it there if that's all right. But big thank you again, Michael and Joanna, for your really great presentations. And if everyone can remember to give feedback, it'd be really appreciated.
Thanks, everybody. Lovely to speak.